Good morning, everyone. First of all, let me thank the organizers and Dr. Balraj for this opportunity. Well, I'm going to talk on unexplained vision loss. I have no financial interest in any aspects of this talk. Well, I know that most of us do practice in centers which may or may not be having this background. I am super happy that Dr. Parni also suffered the same disease what I had, because nowadays the patients are quite well versed. They learn about the disease. They're already Google scholars. They chat GPT, and then they look at your face whether you're telling the same what chat GPT is giving as the answer for the disease. So that's the spectrum what I do practice in Chennai, and hopefully you are not into that, but sooner or later you may face that. So nowadays you have to be very cautious in dealing all the diseases. And now I'm going to take a condition which is unexplained already. So in an unexplained vision loss, you have to be very careful because there are a lot of medical legal pitfalls in it. You have to differentiate a neuropathy versus retinopathy. And because of the atypical presentations, you need a clinical expertise and a comprehensive evaluation for that. And electrophysiological studies, neuroimaging, all do have a vital role in pinning down the causes, because you have to be careful. And this is the group where we may have the malingerers also sitting. So we have to be very cautious about that. As a neuro-ophthalmologist, I'm super happy when I see conditions like this with colorful various disc edemas, and so do the shades of pale. So maybe we can just try a spotter. So what is this type of, is the cursor moving? Yep. So what do you think this type of optic atrophies are? Primary, secondary, what? Okay, this one. Okay. And this one? I think we have residents, but a super ma'am is answering the questions. Are there residents over here? Yes, what type of optic atrophy you see here? Maybe we can make it interactive, please. Exactly. So this is one thing which we had in the morning. A lot of descriptions was given about that. Bot eye, brilliant. And this one? See, already you have made the diagnosis for the pallor of these patients. So that's how we have to pin down the causes. But unfortunately, we have conditions where we don't have that many clinical signs. So there, the most important key is history taking. So for all the neuro-ophthalmic conditions, what you have to do first is sit and decode how the disease started. Because by the time you have finished talking, you know what you're going to see in the patient. That's the first important step we have to follow in our clinical practice. Do not directly go and check the vision. Do not directly go and do the other investigations. Start talking to your patient. What were the associated signs? What did it happen before that? Did he have a viral illness? Did he have any prodrome? Did he travel somewhere? Did he trek? Because I have patients who are group of bikers, they have been branded as optic neuritis, and they sent, and they were referred to me saying that we are going to escalate the treatment. And then I got to know that this guy, wherever he goes in the trek, he sleeps between the bushes. And then I repeated the blood investigation. It turned out to be a scrub typhus. So we can miss subtle things if we miss the history from these patients. So be very cautious about it. So the history taking is the key for most of these conditions. So there can be a sudden darkness or clouding or smudged appearance. That's what they complain as. Their colors can be bleached out. Some patients are smart enough to pick out the type of the visual field defects, which may be altitudinal or an advanced loss, and give importance to transient visual loss. If a patient complains of that prior to the vision loss, you have to be very cautious. So this is the pattern of the vision loss. If there is a gradual progressive dip in the vision, it is invariably a compressive lesion, what you're dealing with if you're going to see as. And if it's a drop in the vision, which did improve by 2 to 3 weeks and stabilized after that, it's optic neuritis. If it's going to be a drop in the vision, which did not recover that greatly, and that is a ischemic etiology. So these are the list of investigations which we do in our clinical armamentarium, apart from the optic nerve function test, anterior segment, posterior segment, electrophysiological investigations, Humphrey visual fields, OCT, Amsler's, ultrasound, and angiogram. The only key is which one you're choosing at that moment is the key, other than the optic nerve and the basic evaluation. So nothing to be less than this pupillary examination. If you see a patient who is claiming that he's having sudden bilateral drop in vision, we have people coming to us, the father is going to almost retire, so the son wants to take over the job. So the father will pretend as if he's lost the vision during the practice. So these malingerers, when they say complete no perception of light and you have a brisk reacting pupil, that's a key. But remember that pupillary disorders cannot happen in a retrochiasmal lesion. So that also you have to be careful. So binocular sluggish pupil is a key for bilateral visual pathway dysfunction. And if it is going to be a relative afferent pupillary defect, which means you're dealing only with one visual pathway dysfunction. And confrontation visual field is very good if you don't have the hi-fi automated perimeter machines, which are actually very good, easy to be done, reproduce, follow up. We can use these automated perimeters, but the bedside confrontation fields is very useful in many times. So these are the pattern of visual field defects, which we can pick up: an altitudinal, a dense central, and an advanced field loss. Every type of visual field loss will give you a clue what type of optic neuropathy or a vision loss we are dealing with. But many a times a patient can come with one eye involvement. But when you do the pupil, it will be a bilateral sluggish pupil. You will have a relative afferent defect, but color vision may be dropped even in the second, which means there is a subclinical involvement of the fellow eye, which only a visual field can pin up. And the next is this OCT. This is an optic nerve cube, and this is the ganglion cell macular cube. Always in neuro-ophthalmology, if you ask for OCT, do ask both RNFL and GCC, which means there is no point of doing only RNFL. RNFL will give you a health of how much of nerve fiber layer thickness is. It is going to tell that whether the disease is, in the recent, or you're going to have a ganglion cell loss also. It will age the disease. Particularly if I have to answer the question what Dr. Balraj had posed, will you treat a bilateral optic neuropathy patient who is walking in with a poor vision? If I see a patient with a pale disc and relatively a good ganglion cell when I do, and if his visual fields is there, compare with his previous visual fields, how he has improved. Always compare with the 3 months old back history to now. He would have had been no perception of light, a PL or a counting finger closed face. And if he's going to be 618 with a fairly good ganglion cell and an RNFL, that's a potential candidate what I will continue to treat. I will refer to a neurologist. So you have to age the disease with OCT, visual fields, and comparison with your previous history and details. Never let go of a patient first time when he comes with a pale disc, because he may end up having 6/6 down the line. And we all know the importance of VEP, so I'm not covering that. And I think we have a talk also. But MFERG is very useful in dense central scotomas, because we have a lot of MFERG signs, which can be non-recordable foveal perifoveal responses, which will help us to decode a macular cause versus an optic nerve cause. And as I said, non-organic vision loss and a functional visual loss, we have a list of evaluations. I think I'm not going to go into the details of this malingering test, which all can be done if you're suspecting a patient is having an unexplained vision loss, just to tell him that you're not having an organic cause. And sometimes we can have occult retinal diseases like maculopathies, paraneoplastic optic neuropathies, and syndromes, vitamin A deficiency and white dot syndromes, which can mimic like a neuroophthalmic condition. So we have to be very careful, get the required investigations and do that. So listening to all these investigations, now I'm going to get the help of you all to decode these challenging cases. We'll move on case-based. So this is a 65-year-old male with a sudden drop in vision, according to the son. But the fellow is saying that I'm having good vision. His pupils are brisk, reacting to light. He's having perception of light. He's got an advanced cataract, and his son is asking me to do the cataract surgery. So the fundus is normal. So what is the next investigation I should do? Okay, fundus was we were able to see even with dense cataracts, so fundus was normal. Yeah, quick. Sorry. I did a VEP. See, I'm seeing a PL vision, dense cataract, but anything in our, we just get a VEP. He's got only a mild delay in latency. There's a relatively good waveforms and still unable to explain. Now I do take the tool what the doctor has suggested, and I did an MRI brain and orbit, and that's what we see. One side a chronic infarct and the other side is a subacute infarct. So that's a bilateral PCA infarct. And this is the candidate who is walking in as a cataract to you. He may have an advanced cataract, but he's not going to get a good vision after the surgery. So you have to be careful about that. So this bilateral PCA knockoff will affect your visual improvement after the surgery. So you have to be very careful in touching such elderly people. So that's a cortical visual impairment following a PCA knockoff. This is a 47-year-old female with bilateral progressive drop in vision for 2 years. And she was diagnosed as open angle glaucoma on anti-glaucoma medication. She's also a systemic hypertensive. Her vision was 6.6 in one eye, normal parameters, left eye 6.12. There was a relative defect. What do you see here? So everything looks fair enough, only a subtle pallor in the left eye. But see this visual field. So it's an advanced loss of field. Only a central tubular field is present. What's the next investigation? I will move on in this because it was not that easy. So ERG was normal. We went ahead for MRI. It showed normal MRI, no lesions, but there was a thinned out nerve and an internal carotid artery was thinned. So then we escalated the blood investigations. ESR was sky high, CRP high, hemoglobin low, and autoimmune workup negative. He had a difference of BP between the arms. We did a physical evaluation. And then the pulse volume also was low in the left arm. So there was a thrill in the right supraclavicular region. And other mammo, PAP, and all the routine evaluations we had done is negative. So she looked like to have a Takayasu's arthritis, and she had an extensive arthritis with critical stenosis of the left common carotid artery. So you can see that, thank you so much. You can see that there is a significant common carotid artery narrowing and all the arteries are narrowed down, the celiac, all these, okay? So that was a case of Takayasu's arthritis. So this is a 17-year-old girl with sudden drop in vision during her exam, normal anterior and fundus. So she was referred as malingering. So she's having hand movements, closed face, pupil sluggish. What next? What is the investigation? Yes, VEP delayed and amplitude is reduced. Fundus is normal. So that's a retrobulbar neuritis, not a malingering. So you have to be very careful because this is one important thing which can be missed easily. So this MRI normal, treated with IVMP, 2 weeks post-treatment, 618 vision, and 1 month later, 69. Color vision improved, but she remained to have central defects in both eyes. So 4 years later, she came with a good vision, but surprisingly, she gave me this history of loss of sensation, unable to hold the objects, and sometimes poor bladder control. So I said, this is something important. You have to repeat your MRI. And this is what is the MRI. So she had classical Dawson's. 4 years later, the initial presentations of RBN where she was asymptomatic. And spine also had some signals. She was put on interferon and then she remained to be stable. So this is a 36-year-old female with a good vision, no RAPD. And this time, the husband is telling she's malingering. What do you ask for next? Which investigation? There's one which is missing in this list. Exactly. So the visual fields. So this is what we came across. So definitely she's not malingering. So she's got a dense enlarged blind spot in the left eye and that of the right eye is normal. So MRI, angio were all fine, apart from mild disc staining. And that's a case of a mutes. It could be an acute idiopathic blind spot enlargement. You have to watch for it. It's a healthy young female who is coming to you after a month. By the time she has reported to you, those faint yellow-white lesions could have settled down. But still, the fields is showing this. So this patient, she opted not to go for steroids. We gave her the options for that, but she said that I don't want steroids and I wish to wait and watch. And this is 4 months later, and this is 10 months later. So she did better without any steroids or so. This is a 74-year-old male with sudden drop in vision. And he said that after cataract surgery, my vision was good. He was 6'6" and 6. And this is the fundus. 6'6" and 6. Fundus is like this. But he's very, very bothered. What is the next investigation? Now you know why he is so troubled. His fields is totally constricted. He's got only, but you see this fundus, what we are seeing. Do you see anything abnormal in this fundus? Sorry? Maybe there are some grainy appearance in the mid-periphery, what we can think of, but the disc, vessels, macula, everything looks good. So with the visual fields of this, what is the next investigation of choice? Exactly. So we went for an ERG, which was non-recordable, and even a VP, there was a drop in the latency and the amplitude. MRI was normal. We escalated the evaluation, and then we found that's a car, and he had a chest CA. So whatever we could see here was a cancer-associated retinopathy, which came with a near normal and a 6'6" vision. So this is a 30-year-old male. In fact, he's a pediatrician. He is one of those guys, what I had explained. He brought an article which I had by mistake presented somewhere. He said that you told that it's MOG, and I want to discuss whether what I'm having is MOG or not. He had 2 relapses, each of them improved with steroids, and now he's having investigations all negative, including NMO MOG. But after a long while of chat, he said that, you know, I'm incidentally also positive for HIV, and I'm on heart therapy. I said, this is more important than the discussion on MOG. And he's a young fellow with a relapsing vision loss, responding to treatment. He's 618 in one eye and other eye was near normal. And you can see, what do you see here? So do you see anything abnormal in this eye? Is the disc normal? So there's a subtle temporal pallor. What else? Sorry? The macula doesn't look healthy, okay? So the macula doesn't look healthy over here, and that of the left eye is normal. So for the ease, I have put the fields like this, but we always have to put it other way, okay? So the right over here and left over here. So this is the right central scotoma, what you see. The MRI was negative. OCT showed fairly good changes, but this autofluorescence gave us more clue. There were a lot of hyper autofluorescence pattern in the macula. I repeated the blood investigation. He's already HIV positive. Now he turned out to be positive for TPHA. He's also syphilis positive, which has been picked up with us. So I said, you have to go to an infectious consultant, start penicillin. By 1 month, he did better. So what we saw was a APM-PPE. What is APM-PPE? Acute posterior placoid chorioretinitis, which can mimic like a neuritis, which will respond to steroids. Probably he had a subtle neuroretinitis also. So this is an 18-year-old female with a drop in the right eye, 636, and she also had ptosis, which was asymptomatic. She said, Madam, already people have evaluated enough for my ptosis. Tell me why I am not having good vision in right eye. I have an MRI brain, which is normal. My fields is normal. And she gives everything on her own the moment you start talking. Her pupils were already dilated and fundus was normal. So what do you think next I have to do? You have a ptosis, you have a vision in the right eye slightly dropped. So what is the next investigation? So we have 2 questions here. Is the ptosis congenital? What is the reason for her vision loss in the right eye? What do I do now? I call the patient again for a pupillary examination. So you see a unilateral ptosis. What do you see here? What do you see here? Is this pupil normal? There is a meiosis. In a ptosis, a meiosis, already MRI brain is normal. What else you would do? Exactly. So I said, what you have screened, you should have gone down. You should have got a head and neck screening, because what I suspected is a right hornus, what she had. And that's the reason for her ptosis and the meiosis. And what she had is a vagal schwannoma, which is sitting there and plexing the sympathetic plexus in the neck and causing this right hornus. And after noticing the ptosis only, she realized her vision drop because she was positive for Wirth dot. What does Wirth dot positivity mean? When do we get Wirth dot positive? Microtropia. So microtropia is a condition which, when we examine and find for the Wirth dot positivity, it's a type of an amblyopia, which you get to know only when you test. Okay. So I will quickly rush about these cases. These were again dropped in vision, 3/60, and dense central defects. And then the patient gives a history of ATT. So you have to be very cautious, ask all the dense central defects, ask for a history of any ATT therapy and ethambutol toxicity, because what do you think if it is going to be, this is a female patient, if the same dense central defects I see, what is the differential? What is the differential diagnosis you would like to give? Okay, tobacco. What else? Male patient. Sorry? Exactly. Lebers. Lebers is one thing which you have to be very careful when a patient comes with sequential vision loss, one eye followed by other eye. And particularly after starting an ATT, because it is proven that all this ATT and all can act like a stressor. They will accelerate an underlying Leber's mutation to manifest. So these patients you have to screen, particularly when they don't respond. Because in ATT, first line, if ethambutol you stop, vision is improving or not, we see. Maybe 4 weeks we wait. Then what is the next thing? Vision will not improve. And then you will say, stop INH. Then the chest physician will look at me. Then what only I will give as ATT. So you're stopping already ethambutol, you stop INH, then what do I do for the ATT? So before going for that, check if it is a Leber's. Okay, that can also be a cause. So this patient did very well. And this is another similar patient, but she had an MDR TB, already treated 2 times, and third time on linezolid. So this is a linezolid toxicity, what we saw. You could see this disc appearance. If you see something like this, be very careful. That could be linezolid toxicity. And after stopping linezolid, did well. And this is the last case. He was referred to me as traumatic optic neuropathy. He had a road traffic accident 4 years back. Right eye normal vision, left eye good, but not that good, and relative afferent defect. You could see that definitely periorbital fractures are there, a sunken globe in the left. What is striking in this fundus photo? Tell me one thing, this is not looking like the diagnosis. Awesome. 4 years history, no pallor. Okay, that is something cheating on you. 4 years, he's having a history of traumatic neuropathy with a CT orbit showing multiple fractures and a 3/60. This is definitely not traumatic neuropathy. And what do you see here? What type of visual field loss we are seeing here? This is a size 5 program. This is size 3. So this is an advanced loss. We heard a wonderful lecture and a very beautiful pictorial diagram by one of the speakers in the early sessions. What type of field loss? Okay, I'm pinning it also. What area it is pointing? In the fields. We will move slowly, madam. So which area is this? You tell me the area. Don't make the diagnosis. Okay, where is the blind spot? Temporal. So what is this? Superotemporal. One eye superotemporal, other eye like this. That's it. That's junctional. And now is your diagnosis. So that's a cellular mass what the patient had. He had a CT orbit. If they would have moved the cut bit up, they would have picked this long back. So that is the cause for his vision. Post surgery, he did recover very well. So in neuro-ophthalmology practice, if you do not know what you're dealing with, the gold standard rule is go back and talk to your patient. That is where we are going to find the diagnosis. So detailed history taking is the key Optic neuropathy, vision loss can be disproportionate to the appearance of the nerve. Maculopathy with vision loss and metamorphopsias can confuse the picture. Amsler testing can be given for sometimes as a home amslers for dense macular causes. Electrophysiology, neuroimaging, visual fields, everything do have a role in finding the cause for these so-called unexplained vision loss, but they are definitely explainable if you do the apt investigations. Thank you so much for your patience.